we're going to go ahead and get to some questions from the audience. So the first one was about the poll. So in the poll, it was about optic pits, and people are mentioning what they do. And it's funny, I'm surprised to see this. 37% said surgery does not help. But why don't you give me your sense, Gaurav, on whether surgery does or does not help for optic pits?
So I think it depends on what you define and what you do during surgery. So that's a big question of, surgery helps. I think surgery done at the right time is one of the right options. You showed very nicely how surgery works. One of the things about surgery is you have to wait for the fluid to go away. It doesn't happen overnight. So maybe sometimes people think surgery doesn't work because the fluid takes a long time to go away. And every pit is different, every anatomy is different. So again, I don't always start with surgery, but I think surgery is a good option when maybe thermal laser hasn't worked. And there's all kinds of different techniques. The thing with optic picks is that they're not that common, so everybody's got a different technique, and it's you kind of remember the only ones that worked. So but I do think surgery works.
Yeah. How about Dr. Talcott? What are your thoughts on that?
Yeah, I mean, similar thoughts. I mean, the other thing you have to keep in mind is sort of what's the goal of surgery, right? So I think that I think your video is really beautiful. And I think you do have to be patient to be able to let the fluid go away. But I think if you're patient or sort of you expect that the vision's going to be the same as what it was like 5 years ago or before the optic pit shows up, even after that fluid goes away, often they've been there for a long time, they might not get all their vision back. And so I think it sort of depends on sort of what your expectation is. I mean, I think that with the right procedure, you can definitely get anatomic success, but that might not mean that, a patient gains significant vision back, unfortunately.
Great, Rishi, can I just add, you showed beautifully in your video the use of the imaging, right? So the imaging for something like this is really important because intraoperative OCT leads you away from doing things you did intend to do, which is cause a macular hole. So I would say imaging, it really helps you in a way of avoiding things during surgery, as much as it helps you during the surgery part. But I think you beautifully showed the use of intraoperative OCT for something like this.
Yeah. Let's get into another question, which I think is related to Dr. Talcott's presentations on the visual outcomes of those macular holes. What was the visual outcome of those macular holes? Did they actually get better, or was it just anatomical closure?
Yeah, I think that's a really good question. So I showed three different holes that I used to close in different ways. I think I include the vision for the last one, and they were able to get about a line or two better. The first case did not get as much improvement back. I think they improved about a line, but the second case, they got about 3 lines back. Finally, the thing is that I don't think those visual outcomes are necessarily even related to the surgical procedure, but you sort of have to keep in mind of how long were those holes there for? And then after they close, you have to look at sort of what the ellipsoid zone looks like. Those are some characteristics that where I use the imaging in clinic to be able to help me, so I sort of see pre-op, do they have that sort of flat open configuration? Is there intraretinal fluid? And that can help me think about what someone's prognosis is going to be. And then similarly, after the surgery, I can look to see what the ellipsoid zone looks like just to be able to get a sense of, is it someone who might continue to have improvement over time, or should, I sort of prepare the patient if they ask that, unfortunately the vision kind of might not dramatically improve over time.
And Rishi, I just want to add to what Catherine's video showed, that a lot of times it's also not about the vision. Many times we deal with we have a large Asian population, a lot of these difficult myopic holes. So they'll tell you that it's their fixation is better. So even though maybe their visual acuity hasn't improved, that they're able to see or fixate in a way they're not constantly searching for things. And patients, now again, hard to quantify, except if you look at microperimetry and all that. But patients actually tell you that their area of fixation is better.
Yeah. And speaking a little bit about that, I think, obviously we have, we showed in all our videos some nice imaging that goes along intraoperatively. So tell me a little bit, Gaurav and Dr. Talcott, like, where do you find it useful? Is it every case? Is it specific cases? Are there scenarios? I'll start with me, and what I did with surgery and imaging is, there'd be those cases, especially when you were doing, for example, retinal detachment, and you'd look and see some translucency in the fovea, and you'd be concerned if it was a macular hole. And the last thing you want to do is go back and drain from that hole because you're going to enlarge it, right? Make it that much bigger. So I used to use it a lot for intraop for management of retinal detachments, making sure the retina was flat, that there wasn't any sort of macular pathology when I did the surgery. But I'd love to hear where you kind of integrating imaging now in your practices. So why don't we start off with Gaurav and then we'll go to Dr. Talcott.
I think that it's, if you're doing a traction retinal detachment, sometimes it's difficult in those cases where the retina is very boggy and edematous to see. Do you have also a recombatogenous component? So as much for macular disease, I think macular disease is fine, but we have a lot of dyes and staining. But I think as we get into more diabetic disease, we're going to find more and more uses in that realm of tractional detachments and helping us have planes that is this retina or is this tissue? And I think that's where I would tend to use it.
Yeah, I think I'm at an academic institution, where I'm training fellows. And so, sometimes, one of the questions that they often have is just like for some of our complex cases, like our PDR TRDs and our PVRDs, the question is like, when do you stop, and I always think that, sometimes the enemy of good is better. And so I find that intraoperative CT is like really helpful in a lot of those cases for sort of helping you figure out when you've achieved your goals and figuring out what's safer and what's not. So like I really utilize Introp OCT a lot for my TRD cases in the setting of PDR because I think it can be really helpful to tell sort of what planes are. Sometimes, I'll lift an ERM or like, VMT in a case. And you could go ahead and PLILM, but if you haven't caused a MAC hole, you can just kind of watch too. So I think intraoperative OCT is really helpful for sort of guiding what additional maneuvers are needed. I don't feel like every case I need to have it to make a decision, but it's often the most challenging cases that it's really nice to be able to have that imaging to be able to help guide your plan.
Yeah, that's a great point. And, I think you beautifully showed three cases of a macular hole kind of repair, but I'd like to ask you like the next level of complexity, which is the autologous holes or autologous transplantation. Are you doing them? Have you found success in it? What is the keys to technique? I'll ask you, and then Gaurav can maybe chime in about his experience with autologous transplantation.
To be honest, I don't use that technique a lot because I find I think it's challenging. I think people show really beautiful videos of it, and I'm sure you guys are better surgeons than I and have a lot of success. But when I've tried to use the technique, it's really challenging. The transplant can sort of get out of place. There's extra maneuvers. So what I've come to really rely on is the subretinal blebs for some of those really challenging cases where there's not ILM left and I can't do a flap. I've had good success with getting that to close, and I think it's a pretty easy technique to use, but Gaurav, I'm interested to hear if you use transplants
Yeah,
to be
I'm
able
actually
to.
just doing a whole talk on when something fails. And it's with myopia here again, it's a different population, but I sort of
Yeah.
have this sort of approach exactly what you do. I do bloods first. If they don't, then I'll do the autologous transplant. And then if that fails, then I mean the amniotic membrane, and then if that fails, we'll take a piece of retina and then move it over. A lot of times we're sometimes faced with a retinal detachment with a myopic hole. And that becomes easier because you can just cut a piece of retina, and put it over. A lot of people make a difference of, what side of the amniotic and so on and so forth. I don't really worry about that part, to be honest with you. I learned from the Europeans, it doesn't really matter. And I typically use either the cryopreserved or dehydrated, amniotic membrane. But I have found that and learned from my colleagues that it does work pretty well. And I typically do that under liquid rather than PFO. It's much easier under liquid than PFO, unlike the autologous.
Yeah. Great comments and great questions, and love the use of the ILM kind of technique of engaging both of um, the finesse loop and other methods. Tell me a little bit about kind of your use of that tool, generally speaking. Are you using it often? Are you using it sometimes? How about Gaurav first and then Dr. Talcott?
I don't really use that tool except for I find a really good use of that tool to take silicone oil droplets behind the lens. It works really well.
Mm-hmm.
But I don't, except in an autologous transplant, I do. Otherwise, I just kind of use a pinch and peel technique.
Mhm.
I have the fellows kind of learn that.
Yeah, I feel like if I left to I agree with you. I think it's excellent the back of the finesse loop for getting the back of like lens opacification. It works super well for getting that. To be honest, when I was in training, I didn't use the flex loop a lot, but I use it a lot more now that I'm in practice. If I'm left to my own devices, I usually just pinch and peel with an ILM forceps. But the flex loop, I think, is a lot easier for people to learn on. I think it's a lot more forgiving rather than just going down and grabbing the retina or pinch and pray, as some people will say. So it's really nice for that to be able to create like a large flap. If I'm going to do some of these like refractory techniques where I'm doing ILM flaps, I think it's really nice because it allows you to create sort of a broad disruption of the ILM and people are less likely to shred. The other thing that I find the flex loop actually really helpful for is if I've got a challenging patient, like there's someone who's breathing a lot and it feels like they're kind of like a moving target under the microscope, or the view is really challenging. The flex tube, I think, just is a lot more forgiving for you to be able to create that large flap so then you can go in with your forceps and pull it across. So it's also nice for lifting hyaloid too, if and Rishi showed that a little bit too, but where you can actually just kind of get an edge. So I didn't use it a lot before, but I've come to feel like it has its role in certain cases.
Yeah. We have a bunch of different viewing systems, and I know Dr. Talcott, you've had experience both with 3D viewing systems from both companies. Can you kind of compare and contrast them for us a little bit, and what your kind of thoughts are on what you've been using so far?
Yeah, I think the Artivo system from Zeiss is a really nice one. The heads-up systems are great. They're really great at engaging sort of everyone in the room and sort of great for definitely teaching trainees. And, often we'll have some med students in the room for engaging them as well. I think it's really nice for sort of macular work, especially because it really sort of like these large monitors really bring things up. I think the Artivo system is nice in that the color feels very real. I think one of the criticisms that you'll sometimes hear about these heads-up systems is some of the peripheral views can be a little challenging, but I think the Artivo does a really nice job of balancing that excellent macular view with the peripheral view.
Yeah. Great. No, good comments. And just to kind of finish up our session, because we have a few minutes left, tell me kind of like what are the unmet needs in imaging for you guys right now from a surgical perspective?
I think if we're talking about sort of imaging in the operating room, like I think our heads up systems that we have are great, and being able to integrate some of the imaging in clinic is great. But it would be nice if there was like even a more like immersive experience where some of the tools that we have more readily available in clinic we had in the OR. Intraop OCT is definitely like a step forward. There is some I think intraoperative FAs that you can use, but I think that, as we look towards this new era of like new viewing systems in the operating room, they really have to sort of be able to offer us things that sort of standard scopes don't. And so I still think there's like room sort of for that moving forward if it's in the peripheral views and those sorts of things. But I mean, it's so exciting in our field. We have so much technology. Whenever sort of trainees think about what they're going into, it's like the best thing about retina is we have all the cool new tools. So I'm just excited to see what the next few years hold for us.
Yeah. And on that note, I want to thank both of you for your case presentations and thank you all for watching.